Hi, I'm Malik Hussain, and this is The Coffee Table. And as always, we've got a fascinating show lined up for you today. We've got one of our favorite things, a medical show. And we are going to be unpicking the mystery of vertigo today on the show. It's such an odd thing. Well, I'm going to leave it to the doctors to tell us more about it, but vertigo in itself is such a debilitating condition to have, and it makes you feel so sick and horrible. And it's also one of those invisible diseases that, like, if you tell somebody that I feel dizzy or that the room is spinning, it's horrible to experience. At the same time, you can also get on with your life, but it severely compromises the quality of your life. And from what I've read, it also sounds really mysterious. Like, what is it? Where does it come from? Many questions that we're going to spend the next 40 minutes picking the brains of our two excellent doctors who are joining us all the way from Islamabad today. I'm delighted to be welcoming on the show Dr. Sajjad Ahmad, who is a consultant audiologist at Shifa International in Islamabad, like I just said. He has degrees in audiology from Washington University in St. Louis and ATSU in Arizona. He is a faculty member of the School of Audiology and Speech Science at the University of British Columbia, Canada, and has also been a mentor, continues to be a mentor for the Hearing Practitioners Program at Grant MacEwan University in Alberta, also in Canada. A little mini geography lesson right here. And we are also so excited to be welcoming back on the show Dr. Shayan Ansari, who is a head and neck and ENT surgeon, also at Shifa International Hospital. He received his ENT training in the United Kingdom. He's worked at University Hospital Cross House in Scotland and specializes in benign and malignant head and neck pathologies. Welcome to the show, doctors. This is very exciting. So I like to begin at the beginning, as I always say. So Dr. Sajjad, tell me, what is vertigo? How do we define it?
Vertigo is a very broad term, basically, the way it sounded, and unfortunately, it's been depicted differently. People who got little dizziness, they would call it a vertigo. On other side, vertigo could be very debilitating, as you stated, and could have more causes behind it.
Right.
So it's a broad term, basically, and it's a feeling of sensation, spinning sensation, things moving around, dizziness, unsteadiness. When the coordination of three important parts of your body are not working, which is your vision, your proprioception, the feeling of being aware of your surroundings. On top of that, your cochlea, which is the part of the inner ear where things happen. So in general, it causes dizziness, spinning sensations. That's how people feel. And everybody calls it a vertigo. But each dizziness is not a vertigo, not a true vertigo.
Oh, okay. So how do we differentiate between regular dizziness and a vertiginous dizziness?
Dizziness, the usual dizziness is a temporary sensation of unsteadiness.
Right.
You get off balance. Whereas true vertigo is spinning sensations, things around you are moving, or you feel that you are moving in space. That drives you crazy for sure. So these are two different things, but in general, people call it as a vertigo. But the first thing is that we counsel patients that you got dizziness, you got unsteadiness, not really a vertigo.
Yeah.
That's how we start.
Oh, okay. So it's a sort of, one has to kind of start like the onion, sort of peeling away those layers to kind of differentiate between a feeling of unsteadiness, which is a balance issue, versus spinning, which is something completely different. And that sort of, I assume, is what's going on in your ear. So Dr. Sajjad, you did mention that vertigo happens when our sort of the balance of these three elements is sort of disrupted. But Dr. Shayan, when we're talking about our sort of sense of perception and our sense of balance, all of that comes from the ear, doesn't it? It sort of has to do with your inner ear and the fluid floating around there. Look at me, layperson, struggling.
But that's okay. I'll just start. ear is one of the organs of balance. So there are
Right.
other organs of balance as well.
Okay.
Now, as Dr. Sajjad mentioned, that dizzy feeling is a temporary and a short-lived feeling, and
Okay.
anyone can get dizziness. Okay, vertigo is a constant sense of illusion of room spinning or unsteadiness, or just as if you've come off a merry-go-round. So that feeling is vertigo. Now. Everyone would have a dizzy spell. I clearly remember a few years ago, my daughter, I was turning around and she said, "Slow down, I'm feeling dizzy." And she was
Yeah.
5-year-old at that
Yeah.
time. So, so you can well imagine that how common dizzy spells are. But when it comes to vertigo, then the thing you have to look for is it, a constant feeling that's going on, and what other symptoms they are getting along with it. And balance, as you asked me, what are the organs of balance?
Yeah.
Then ears is one of the organs of balance. Then your eyes are other organ of balance.
Oh.
And very surprisingly, your legs, that is also organ of balance.
Right.
So these all, they work with the coordination with your brain, and they provide balance in your body.
Yeah.
So when you start getting vertigo symptoms, then we try to look for the causes for it, and we try to exclude all of these. Most of the time, the cause is inner ear. And one of the examples we very commonly give to our patients is that, like an aeroplane which has two wings, and if one wing you take it off, the aeroplane will go round and round. Same is your inner ear. They are like two wings of your balance, which balances your body. If you take one off, you'll go round and round. So that's the organ of balance. That's how our ear works.
So it also sounds like a condition like vertigo is, it sounds like it's complicated to diagnose also, because it seems like that the brain is involved, the eyes are involved, the ears are involved. So sort of, are we able to, what are the general causes of vertigo other than the ear?
And there, when people come to my dizzy clinic, we have a clinic which is called as a dizzy clinic, and people come to those clinic, and we spend time with them, and we ask them questions, and it starts from the moment the person walks in your room. So you look at the person walking in your room, look at it, his gait, how is he walking in the room? That gives a lot of answers as well. Then you start talking to the person, and when you're talking to that person, then you start getting information out of him, whether this is a true sense of vertigo or is a dizzy spell, as I mentioned to you. And then you start asking about other systemic causes. There are more than 100 causes of vertigo you can sit and identify.
Wow.
But if he's come to my dizzy clinic, I'm more interested in ears and things, whether I can there are two objectives which I have in my clinic when I see a patient. One is, I hope there's nothing sinister happening.
Yes.
And secondly, will I be able to fix him or not? So when we start looking at these patients, we follow these two pathways. And first is that we try to find out, because people who can get, young people can get stroke and, a mini stroke, and that he can present with vertigo symptoms as well. So that is a slightly sinister cause for it, because, your brain is the central processing unit which will do it. And similarly, people can have, problems with their eyesight, which can give them a bit of unsteadiness. So, there can be a small cause and a very sinister cause. So that's how we start to distinguish. And then it comes to ears. When it comes to ears, we start looking in the ear. We do the hearing test. We do vestibular testing. And then we do a few positional tests, like we move them around the clinic. We ask them to sit and lie down. We move them around the couch, which sometimes people feel, is this doctor really joking with us here? But all of these give us an answer. And there are certain causes coming from ears which are treatable, and there are people who we have treated who had vertigo symptoms for years and years. They've come to our clinic and we found out, that was positional and was being missed out, and we did all these positional tests, and we did their maneuvers, like Epley maneuvers. And
I'm going to ask you a little bit more about that. I'm going to ask you a little more about that anon. I'm just like, don't give everything away just now. So Dr. Sajjad, like Dr. Shayan mentioned, it seems like suffering from vertigo is not an age. Is there a sort of an age range, or that in which this sort of this condition you're more susceptible to? Because from what I understand, vertigo isn't necessarily a disease. It's more like a symptom of other things.
It is. Basically, it is a symptom, and it's a hallmark. And as Shayan pointed out, that everything lies in the history.
Right.
The first and the foremost thing is to take a very careful history, that what was the onset, what's the frequency, was it sudden, is it repeatedly done or not, all those kind of things. And beyond that, then you try to explore what are the causes there. It can be any age, but it's mostly seen in seniors or
Right.
people with chronic diseases, diabetes, hypertension, so those kind of things. But one thing which I'm noticing, the younger lot coming in and complaining of vertigo or dizziness for that matter. And one of my pertinent questions to them are, how much is your screen time? How
Oh
much time do you really spend on your cell phone or on your laptops or computers or watching TV? And most of the time, and I jokingly, I always tell them, must be 5 or 10 minutes a day kind of thing. And then they laugh about it.
As I am now, as I too am guiltily laughing about.
You want to make them comfortable to talk to them.
Yeah.
And then they come out with, yes, I spend about 5 to 6 hours or 8 hours. Well, one of the reasons could be online classes, the other could be other social reasons, that you are hooked up to a cell phone, and your neck is always in a bending position.
Oh, so the problem is the neck. So
That's
it's
true.
not,
your muscles get stiff.
oh, so it's not so much blue light from the screen that's messing up your eyes. It has more to do with your neck being bent, awkward position for a long time.
Right. Then you tell them, okay, how much break do you take in between? They say, well, constantly. We are there for hours together. So this is what happens when your neck muscles get stiff. And all of a sudden you try to move out, you get a spinning sensation. You got dizziness, unsteadiness, because your one side of the muscles are stiffer than the other side. You've got 2 ears, and so the body balance is maintained by both sides.
Right.
So if the 2 ears get a different sensation, there's an incoordination, and then the brain tries to reset it. In that phase, you get dizziness, and you get unsteadiness and vertigo kind of feeling. So that's what I've noticed lately in
That's
younger.
fascinating. So, Dr. Shayan, does vertigo in older people, why does that happen generally? Why do older people tend to get it? Or
Again, as I said, with the passage of time, the body physiologically starts to get old as well.
Right.
So your eyesight starts to get weak, your hearing starts to get weak, your muscles in the leg, which are supplying the brain, starts to get weak, and the processing center in the brain also starts to get slower with time. So people can get dizzy spells as they grow. But again, as we see these people, first thing which we have to make sure that this is not a sudden onset thing. This is not something which we are missing out, because an older person can get stroke as well, can have big problems in the brain where they have the small vessels in the brain getting bit calcified, and things like those can happen. So we try to look at all the causes, and again it can also be because of your heart problems as well. If you have a heart problem, then you can get disease spells as well. So when these patients come to our clinic, as we were discussing, that we take a detailed history, and first thing which we have to look out is whether they have true vertigo or not. So true vertigo for us, for ENT people, is something which is coming from the ears. So we take it as a true vertigo, that we will deal with it, otherwise we will send it to the relevant person. So we take it from the history. Like for instance, if a person comes up and he says, Dr. Saab, I am getting dizzy spells, and when we ask him, he says, well, it feels like that my energy is drained from my body when I
Yes.
stand up, or I get bit
Like people.
fainted or lightheaded when I stand up. That's
Yeah.
not a true vertigo. That
Yeah.
is lightheadedness, and the cause for that is usually vascular or to do with your heart.
Yes.
Same if people come and say, oh, we had severe headache and then the vertigo started, then you think about something coming from the brain.
Yeah.
So these first thing which we have to find out whether this is a true vertigo or which is something else. And if it's true vertigo, then history is very
crucial,
important. Exactly, and it gives us almost a diagnosis, and our tests are there just to confirm them. Like for instance, if a person says that Dr. Saab, it started all of a sudden and I was in the bed, and when I roll in the bed I get room spinning feeling. That is positional vertigo, very typical positional vertigo. People
so that's
say,
it's an actual thing, because I think a lot of times people think that vertigo only happens if you're standing up or you're walking around, but you can experience that spinning feeling even when you're lying down.
We have so many people who come to us with different things. We want people who come and say, oh, when we look up and we feel the room spinning or we feel lightheaded, that is to do with your spine. Your spine takes all the messages to the brain. If the vessels, your blood flow or your nerve roots are getting compressed there, then they can give you the dizzy feeling as well. So that's how we work. First we look at for the causes for the true vertigo, and then different causes for it, and then we try to
and then we proceed. And we too are going to proceed by taking a very quick break at this juncture. We'll be back in a flash. Stay with us. Welcome back to the coffee table. We're having an absorbing conversation about vertigo. I'm not sure how to pronounce it. Good thing we've got two doctors on the show who do know. We are in conversation with Dr. Sajjad Ahmad, a consultant audiologist at Shifa International Hospital, and Dr. Shayan Ansari, who is an ENT head and neck surgeon, also at Shifa International. Now, before the break, we were talking about sort of different kinds, really, of vertigo. And from what I understand, Dr. Sajjad, there are two sort of main categories of vertigo. So there's peripheral vertigo and there's central vertigo. So could you tell me a little bit about what peripheral vertigo entails?
Basically, there's another term for this, is that the cause is not lying in the brain, it's in the periphery of the brain. Hearing is a peripheral part.
Oh, that's why it's peripheral vertigo. Okay.
That's true. And it's called benign paroxysmal positional vertigo.
Yes.
That means that it happens because of the postural changes in your body.
Right.
And then the central would be some central cause where there could be some space-occupying lesion, some infarct in the brain, blood supply occlusion. Those things can cause that could be a central vertigo. So peripheral and vertigo are slightly different, and when they come to audiology, we try to exclude the peripheral part first.
Yes.
We do the hearing assessments, and we've got other tests too, which are positional tests which we do in the clinic.
Yeah.
Besides that, you could still do a few more tests like VNG, visual technography. You could do CDP, computerized dynamic posturography. These are the tests. You could VEMS, vestibular myogenic potentials. All these tests give us more information whether the cause is peripheral or central.
Right. So in BPPV, which I think is the correct acronym, could you explain why that happens? Because I know that it has to do with your inner ear and the fluid in it and things floating around in it. I find it really interesting. So I would just like for you to tell me a little bit more about that. Like, how does the position of your head affect your sense of balance?
Okay, now the auditory system has got two things in it. It's got a hearing and it's got the balance part.
Right.
The hearing part is dealt with cochlea, inside the cochlea, and the balance part is by the semicircular canals, which are three semicircular canals on each side.
Right.
And there are some particles in this autoconia which float around and keep the balance of the body. As the particles move, they give sensations to the brain from both sides. If there's an incoordination between the two, then it can cause vertigo. Now, these particles, they get stuck in one part or they get accumulated in one part of the semicervical canal, whereas on the other side, it's not the same. And
Right.
because of this, when you change the positions, brain gets a different sensation from right and the left side.
Oh.
And the brain tries to correct it. That's what we do, all maneuvers, whatever Epley maneuvers or
Yes.
Dix-Hallpike maneuvers. We do all these maneuvers to get the positions in place. So these particles are then moved around in the fluid and they come back to the resting position and the vertigo settles down. It doesn't happen all of a sudden. It
Yeah.
takes time, or you give them some exercises to do it. So basically, these autoconia, the particles which are in the perilymph and in the endolymph, that's where the problem is.
Right. That's so fascinating. And it's also such a delicate balance because these tiny particles are the ones that are responsible for sending these signals. Is there sort of, and I get a very layperson question, Dr. Sajjad, but is it possible that with age or with time, those particles increase or decrease? Does that also happen, or is it just a matter of positionality?
It does happen with age too, especially in conditions like Menieres. You can have this feature that there will be a lot of fluid in the endolymphatic sac, which is a part of the inner ear, on one side or the other side, and that can give different sensations to the brain.
Yeah.
So it can happen at any age, but more so in the seniors.
Right, and I'm glad you mentioned Menieres because that's also something I have several questions about, but anon. So, Dr. Shayan, tell me a little bit more about central vertigo, because also as a surgeon, I realized that this is something that's more connected to the brain and the brain interpreting signals, and that's probably something that you see more often in your clinic. Again, I'm just presuming.
We usually screen them out, basically. And if it's a central cause, then we try to look for the cause. As Dr. Sajjad mentioned, it could be a physical cause there, like some sort of a space-occupying lesion, which he mentioned, which means there's a small growth, benign or malignant, can be there. It can be the blood vessels in the brain starts to, with the passage of time, they start to get more stiffened, basically.
Yes,
so
like
you can
said,
get
they get
ischemic changes. Exactly. So you can get ischemic changes in the brain, and then importantly, you can get stroke and things like that as well as a central cause. So as soon as a person, we are examining and seeing the history also gives away, but when we examine them, we look for the causes. And like, for instance, if it's a peripheral cause, like a positional vertigo, then we do positional testings that will be positive. Whereas if we are suspecting central cause, then we will do tests for central causes and they would be positive. And then we find out and then we usually send them for scans. Like from the history and examination, we try to determine which one is it, and then we do the test to prove it. And then if it's central cause, then our next step would be to get imaging, some sort of MRI scan or a CT scan, look for it in detail. There are a couple of sorry?
No, I was just curious at which form of vertigo is more commonly found. I'm assuming it's probably positional, but it's better to ask a doctor.
In younger people, we see positional more common.
Right.
In elderly or senior citizens, we see central more often. And as you asked, Dr. Sajjad, that with the passage of time, does these particles degenerate? All the cells in the body degenerate. This is a physiological aging process. And the way around it is that we compensate them. So what we do is we tell all these patients or people that they have to do exercises. And these are vestibular exercises. And they strengthen these. Like if, for instance, if you have got 5 out of 10 cells left, those 5, if we strengthen them, they will compensate for the 5 which are gone.
Quite right.
That is the important bit. And
they're flexing their muscles.
Absolutely.
So, Doctor, tell me a little bit about these maneuvers. I understand that there's an Epley maneuver, and then there's also a Brandt-Daroff maneuver as well. What are those? What's an
maneuver is what happens is, as Dr. Sajjad was telling you,
Yes.
that these particles in the channel get stuck. So there are 3 channels. So when people come in, we, again, as I said, from the history, we are kind of knowing what we are suspecting. So we do these maneuver. First is a Dix-Hallpike maneuver, which is a positional testing, which we do,
Right.
or
What does it look
head
like?
thrust maneuver.
Is that sort of, when people like, oh, you just rotate your neck and it'll help. Does it look like that?
Exactly. So we ask them to sit, and we move their head to one side, and then we ask them to lie down with keeping their eyes open, and their head goes beyond their beyond the couch, so it's below the level of their shoulders. And we look in their eyes and we see, and if they are having this BPPV, depending upon the canal and depending upon the maneuver we are doing, we find out their eyes start to move. This is the way it shows us that that there is a problem there. And once we identify the problem, then we, as I said, we have to do the maneuvers to get those particles realigned. So the most common one is Epley's maneuver, because the most common problems lie in the canal that the Epley maneuver fixes. So we do Epley's maneuver, and about 85% of the time, Epley maneuver works in the first instance, and which is very good.
Wow.
Absolutely.
And can the Epley maneuver be done at home by yourself, or do you need to be supervised by a medical professional?
We tell our all our patients that first time it should be done under supervision, but it can be done at home. If you look at YouTube videos, there are home Epley maneuvers given as well. But what happens is that when you do these maneuvers, you get a lot of dizziness, a lot of vertigo, and you can get sick with it, and then people start to lose confidence. So if they do at home, then there would be nobody to reassure them with with them. So that's why we say first time do it in the hospital, so that we can reassure them, tell them, okay, that's how you feel when you do it. So that is very important. But if there are a number of times when people come to me from far-flung areas and they haven't brought somebody with me, and I don't want to do the Epleys there and then, because I know that they will get dizzy and they won't be able to travel.
For them.
Absolutely. Then we give them the instructions to do it at home as well. So that's Epley's. Now, brand direct, which you asked. And the brand direct you asked, these are compensatory exercises. So these are the exercises which we give to our patients when they are having positional vertigo to do it from home. They are very simple. You look in the roof, make your head to 45 degrees, lie on one side 3 times, lie on the other side 3 times, do it 3 times a day. And what it is doing is it's just making the other canals compensate better and getting the mind to look, to calibrate your full body with your environment.
That's really interesting. You're sort of training your brain to receive the signals it's getting and to interpret them properly by doing exercises that kind of seem silly, like lie on your left, lie on your right, but you're basically kind of resetting that whole system. That's so fascinating. I love science. But Dr. Sajjad, I want to come back now to Meniere's disease, because that's something that came up a lot when I was reading up about vertigo. So what is Meniere's disease?
Actually, it's a development of, we call it, technically speaking, endolymphatic hydrops, that the fluid gets accumulated into the utricosacule of the cochlea. And the chemical composition of that fluid works in such a way that you get dizzy, basically. Once it's a fluid-filled cavity, so you have to drain that fluid. You don't drain it physically, but you do medications like diuretics and stuff. And normally these patients do have either they are hypertensive or they've got any other underlying disease like diabetes kind of stuff. So you treat them medically.
Okay, so it seems to be a condition that is a sort of subset of having another condition previously. It's not something that you can sort of catch on your own or develop, I said, but not catch, not a virus. It's something that you can't develop on your own.
No, it just happens. That's it.
Okay, and Meniere's disease can be... sorry. Yes, carry on.
Yeah, sure.
No, you were saying.
Yeah, Meniere's disease is treatable. I mean, these are people who have got chronic diseases, so they get treated by the respective physicians or ENTs for that matter.
Now, we've been also talking vestibular treatment, and I know that vestibular neuronitis is also one reason why people suffer from vertigo. So what is that?
It's an infection. It's a virus. Generally, it's a viral infection.
Right.
And it causes neuronitis. And when the neuronitis happens, then again, the information going to the brain gets into disarray. Once it goes into disarray, as I told you before, that if two sides of the body do not coordinate well, the brain tries to fix it, and in that phase, you get dizziness.
Right, right. So is not the same as an ear infection, is it?
No, ear infection is something different. Like you've got otitis externa, you've got otitis media, you've got chronic suppurative otitis media, where the infection travels to the inner ear, and if for some reason complications happen and it travels to the brain, then you get that kind of stuff.
Oh, okay.
Generally, you can't be ignoring chronic suppurative otitis media, where the infection has traveled to the inner ear.
Oh, okay. Is there a test for that?
There are tests. I mean, we basically do the hearing test first to figure out that where is the infection lying, where is it? You know, sometimes as simple as an impacted wax or cerumen in the canal can give you dizziness too. It's not vertigo, it can give you dizziness.
Yeah.
But so you have to look at the simple things and then you go into the further investigations. So hearing tests are there, the impedance audiometry, which gives us some information.
Yeah.
And generally, once we figure out that it's a vertigo of central origin, we go for the scans, MRIs and CT scans, and try to rule out the space-occupying lesions.
Yeah, yeah. Ooh, space occupations. You know, I read a lot of sci-fi, so my mind goes off to a spaceship. We're going to take a very quick break so I can stop being such a nerd, and we will come back in just 1 minute. Stay with us. Welcome back to the coffee table. We've been having a really interesting, mind-turning conversation about vertigo with Dr. Sajjad Ahmad, who is a consultant audiologist at Shifa International, and Dr. Shayan Ansari, who is an ENT and head and neck surgeon, also at Shifa International. So we've been sort of really dissecting vertigo left and right, and I have learned so much, actually. Isn't really great. But I'm also now curious about other things, as I always am. So Dr. Shayan, we know that the treatments for vertigo seem to also be dependent on where the vertigo is actually coming from. So if we're looking at a lesion on the brain, then we look at that. Or if we're looking at inner ear trouble, where that's an issue. But I know that also migraines also seem to be one kind of byproduct of having vertigo, or vice versa. So what's happening there with migraines and vertigo?
Absolutely. Migraines and Menieres, they sometimes go hand in hand,
right?
And they are kind of diseases or conditions which we don't know a lot about. And what we are trying to do is when we see these patients, we try to manage them, because there's no physical thing there which can be corrected surgically or with the thing. So what we do is we try to manage those episodes coming up. So basically, as you know, I'm very sure people know a lot about migraines, because when they get the warning signs. Same is with Menieres. They get the warning signs with it.
What are those warning signs, for example? Because I think a lot of people might be getting them and then kind of ignore it, that no, it's not a big deal.
For Menieres, again, we say that people usually get aura symptoms, like they get fullness in the ears, they would get ringing sensation in the ears, the hearing will start to go in one side, and they would know that the attack is coming up, basically. And what they do is the same as with the migraines. They find a dark corner in the room or house, and they go and curl up there for a couple of hours, and they'll be fine, basically. And this is why we say the migraine and Menieres are kind of similar conditions, and both of them are diseases of exclusion. Like if a person comes to me, it is very important for me to exclude everything else before I label it Menieres or like, for instance, migraine. So we do the scans, and people, there are times people come in and say, "Oh, Dr. Saab, I know I have Menieres, but you are asking me to do a scan, and after that you will tell me again it's Menieres. So why do I have to do the scan?" But there are times where we do the scan and find out, oh no, it was not Menieres. There was something else happening. So so those are the rules of management. For Menieres, you do get the aura symptoms, so people know about the attack coming up.
Right. So is it the same for vertigo also? Because is it possible to treat vertigo so that it completely goes away? Is that possible? Or just some people just have to live with it? Because like you said, there are some conditions that we don't know that much about. So we're not really able to pin it to one sort of specific problem.
Now, there are conditions which we can treat completely, like benign proximal positional vertigo. We can treat it. Menieres, what we can do is we can increase the interval of these attacks. People who are getting, very frequently, we can make them come once a year, but you cannot get rid of them. Similar, just like migraine. Then vestibular neuronitis, as you said, they stay for a couple of days, and after that they get the sense of unsteadiness for a few weeks afterwards. But then it goes away. So there are types of vertigo, depending upon why you're getting the vertigo, it can be treated. But whatever the cause is, this I tell all my patients, whatever the cause is, what the person has to do is do some vestibular exercises, because whatever the cause is, if you do the exercises, it will help you compensate. Your mind is a very dynamic organ in your body. It learns everything again, and you train it and you can get rid of it. But if you get hooked to it, then it will put you in bed.
That's good. So Dr. Sajjad, previously we were talking about the neck and balance. So I am curious now that how important is our posture when it comes to balance and dizziness, or sort of trying to prevent it, because we do have very sedentary lifestyles and we do spend a lot of time kind of hunched over our desks. And now with the COVID as well, with the pandemic, we've been working from home, and there's even more hunching over desks and over screens. So what is the sort of connection between our posture and what's going on up here?
Okay, one of the things which is very well known in medical field is the vertebral basilar insufficiency. You've got blood vessels going through your neck and going to the brain. So if your posture is wrong, it's likely that you might pinch some vessel, and for some reason it gets constricted and you've got less blood supply to the brain. That can cause it. But that can cause it. But at the same time, your muscles get tense. If your posture stays in a position for a long period of time, you're likely to develop a hunch there.
Yes.
And it used to be, when the computers came in, there used to be directions that every 30 minutes you work on your computer, laptop, or anything, you should take a break of 5 or 10 minutes. It used to be mandatory in Western part of the world, so that people should relax their muscles, move around, and then get back to the screen. But somehow you should be doing that practice. I would suggest that's very important. So it's basically the blood supply occlusion and the stiffness of the muscles, and the muscles give a sensation to the brain and to the vestibular system that this is what's happening. And whenever there's an incoordination, you'll get dizziness. This is how it is.
Right. So as we are talking, I am putting my shoulders back because I'm just like, oh my goodness. Because again, the body is such a finely balanced machine where any little thing goes off and then, you really lands you in the soup, as it were. So Dr. Shayan, you run your dizziness clinic, and we have, I think, both you and Dr. Sajjad have explained really beautifully the difference between dizziness and true vertigo. But how much dizziness or how many sort of episodes of vertigo fall within a normal range? Like, when should you start to worry that this is not okay?
Yes, if you are getting something constantly, like if you're getting this feeling of room spinning, or as if you have come off a merry-go-round, or you feel unsteady in your gait, and this lasts for a couple of days, then I think it's time to get it checked.
Oh.
Sometimes it is associated with nausea and vomiting and other symptoms, then obviously you should get it checked. If you're getting pain in your ears or headaches, then you should get it checked. So one-off dizzy spell, like if you turned and you had a dizzy spell, okay, fine, you can ignore it. Or one evening you had a bit of dizziness and it didn't change into something sinister, and by resting it went away. That is fine, because people who, if you have rigorous exercises, workouts, you can get a bit of dizziness, but those are short lasting. Couple of hours will go away. But if it's a short lasting happening again and again, like every day you're getting same feeling, then again you should get it checked. So something which is happening very regularly with intervals, or something which is constantly persisting, you should get it checked.
Right. Yeah. Then it's important to sort of consider those things as well, because I think a lot of times people will experience something regularly, and then in a strange way you normalize it because it doesn't affect your life in any other way. So you're like, oh well, it just happened briefly and it's okay now, and you just sort of carry on with that. Dr. Sajjad, in sort of now that we're nearing the end of the show, one last thing I'm curious about is that is there a connection between chronic allergies and having these vertiginous episodes as well?
Not really. If migraine are related to any allergy, that is different, but no, really chronic allergies as such, no. But medications do. If you are on long-term medications for chronic diseases, that can impact, that can cause dizziness, that can cause vertigo, depending upon how much you take. If you've got anxiety disorders, you can still get dizziness. Those are also important in real life. And if your blood pressure goes down because of one of the medications, you can feel dizzy. For vertigo, we've already talked a lot about vertigo.
Yes.
So what are the conditions? The whole thing is that you should not ignore it. You must have a consultation with your ENT. You should have a consultation with neurologists. You should have a consultation with your audiologist. Audiology used to be a field people thought is just all about hearing. But audiology is a composite field which deals hearing and balance disorders.
Absolutely.
There's lots of investigations in that, and we are lucky here in Shifa that we are able to combine both the specialities and run a dizziness clinic. So we're looking forward to doing more on this.
That's still. And thank you so much, Dr. Sajjad and Dr. Shayan, for joining me today and letting me pick your brains about dizziness and vertigo and all the different sort of reasons why and wherefore it happens. And I think that one thing that I found particularly interesting was that age is no bar. Dizziness and vertigo does happen in older patients generally, but if you are a younger person experiencing persistent symptoms, then please don't ignore it and go and see your audiologist, go and see your ENT specialist, and look after yourselves. If you're watching this on YouTube, don't forget to like and subscribe. Remember to sit up straight and take a break from the screen once in a while. And we will see you next time on the coffee table. Bye.